interventional radiology, especially the uterine artery embolization. I am sure everyone of us must have heard one of his talks. So welcome, sir. We expect to learn a lot more.
Good evening, everyone. I would like to thank Dr. Radha Lakshmi ma'am and Venkatramana sir for providing me this opportunity. So today we will discuss a brief overview about sonohysterogram and sonohysterosalpingogram. So there are four modalities. One is sonohysterogram, sonosalpingogram, and when we use contrast, we will call it as hysterosalpingo contrast sonography, and saline infusion contrast sonosalpingography. So introduction, it is a minimally invasive ultrasound technique where we can see the enhanced visualization of the uterine whenever there is a dark background which is saline. Advantages, it offers a very clear imaging rather than routine TVS. So when we order sonohysterography means whenever there is a abnormal uterine bleeding with inconclusive TVS findings and infertility assessment and recurrent pregnancy loss. So contraindications, pregnancy is a contraindication, and active pelvic infection which can worsen the present clinical condition are the absolute contraindications, and relative contraindications are like vaginal bleeding, active vaginal bleeding which can obscure the imaging quality. So optimal timing is on 6th to 10th day. And procedural steps are we give pre-medication of with diclofenac and buscopan to relieve anxiety and pain, and the patient will be kept on lithotomy position with a baseline ultrasound TVS findings noted, and cervical cleaning will be done with betadine, and an 8 French Foley's catheter will be introduced, and saline will be instilled into the endometrial cavity, and TVS is then performed. So the common diagnosis which we see in sonohysterogram are this is a case of endometrial polyp where we can see a sessile pedicle, and this is the saline which we have injected, and this is a vascularity in the center. So this is a case of endometrial polyp, and same thing in a endometrial blood clot where it is a freely mobile clot and with a different echogenicity depending upon the age of clot. And this has a major role like sonohysterogram where we can see adhesions in Asherman syndrome, where we can see clearly the adhesive band. This is a routine TVS finding. But however, if we instill the saline into the endometrial cavity, we can see clearly the bands. So this will also help to identify submucosal fibroid where it will be broad-based towards, and it will be lined clearly by the endometrium. And sometimes when there is dense calcification, we can see poor sound transmission because of dense acoustic shadowing. So complications, generally this procedure is well tolerated with minor spotting and minor pelvic cramping. So coming on to sonohysterosalpingogram where we image tubes rather than the uterine cavity. This is mainly to look for, to evaluate the cause for tubal cause of infertility. So basically it is of 3 types where we can use contrast or whether we can use plain saline. So as same like sonohysterogram, sonosalpingogram baseline steps are normal. However, we inject around 20 to 30 ml of saline without mixing of the bubbles to look for the tubes. So assessment is like when we place a color Doppler imaging, we can see the color bruit on color Doppler imaging indicating the patent tube. So that we call it as waterfall sign. If there is no color buoy, we can call it as absent waterfall sign. So alternatively, we can also diagnose with the help of the presence of free fluid in the pelvis which is mixed with air. This will also point out towards the patent tube. So whenever we use contrast, we will call it as hysterosalpingo-contrast sonography. Instead of giving saline, we use contrast agents such as Ecovis, Sonoview or Lignosal. So it is basically same thing where we inject contrast agents instead of saline. So if there is no contrast available with us, we can make ourselves as lignosal, where we mix 4 ml of lignocaine jelly with the 20 to 30 ml of saline. We will mix it on a 3-way until we get a vigorous whitish contrast was obtained, and this is injected into the uterine cavity instead of normal saline. So we can clearly identify tubal patency on the contrast sonography, where we can see this is a shower of in the peritoneal cavity, a shower of ultrasound contrast in the peritoneal cavity. And we can call it as turbulent sign and shower sign and ring sign. Ring sign is where the contrast will be encasing surrounding the ovary. So these are the signs where we can see the distal end of the fallopian tube, fimbriae, and this is the contrast which was overspilled, so indicating patent tube. So this is called as a skirt sign. And if we see localized spill which indicates partial tubal block, we can see it as a this pointer, only a focal spill is seen. Sometimes we can see there is no spill. So this can be seen as a blunted fallopian tube without any fimbriae. So controversies: lack of clear-cut evaluation criteria for a partial obstruction, and clear-cut evaluation criteria is also not there. So these are the controversies in contrast enhanced saline salpingography. So this is the last modality where we can, after confirming the tubal patency, we will inject more and more contrast agent to look for the detailed evaluation of the fimbria. So in this part we can see clearly in this SIPS procedure we can see the fimbrial very clearly, and this is the outlined ovary, and this is the background saline and contrast media. And once we inject the jet, we can see the free spill from the fallopian tube. So this procedure is to look for the detailed evaluation of the fimbria. So normal indicators for fimbria are count more than 3 with width around 2 to 4 mm with clear-cut boundaries and homogeneous hypoechogenicity, and with perifimbrial adhesive bands less than 2, and with finger-like protrusions which are separated well from each other. So abnormal indicators are opposite of normal indicators with count less than 3 with finger-like protrusions or showing a fist sign which are crumpled together with multiple intrawebs in between the fimbriae with no clear demarcation. So these are the pathological fimbriae. We can see clearly there is no clear-cut protrusions, which these are fused together with inhomogeneous echogenicity, and here we can see adhesive bands, peri-adhesive bands. So advantages are procedure is well tolerated without any radiation. And the intrauterine saline injections require only less amount of saline instillation rather than transfornial and transabdominal instillation. So the adverse effect reactions are not much, only mild pain or vasovagal reactions which can be easily tolerated. So this is a basically overview chart where saline salpingography has advantages over HSG and laparoscopy. So congenital abnormalities and cervicitis, the uterine evaluation can be done with saline salpingography with the help of ultrasound, and patency and mobility of the tubes can be easily assessed with the help of instillation of saline through the endometrial cavity. Thank you. I would like to thank once again Dr. Radha Lakshmi ma'am and Venkatramana sir for providing me this opportunity.
Thank you, sir, for the elaborate session.